Thank you, Tony. And just before I start, I'd just like to thank RA for the opportunity to come and talk about this. And those of you, that have been to RA and been to Seattle and coming to these, you'll understand that it is a journey. It's a really exciting journey. And the more times that we get to share about experiences and to share different components of those steps, the more we learn and the more we have great conversations with each other. So I'm going to talk a little bit today about two very different AED programs for first responders. So I'm going to talk a little bit about life-saving, and I'll talk about fire and our experience in Victoria in that. And there may be some, things that resonate for you. It was challenging, and I'm going to talk take a little bit of time to talk about some of the challenges and, the way that we overcome some of those things. So just like we've heard before, if you've seen one first responder program, you've seen one first responder program, and they vary and they are, different and complex. So I'm going to talk a little bit about fire, both Metropolitan Fire and our Country Fire Authority. I'm going to talk a little bit about a program in surf lifesaving. So the other hat that I wear is a surf lifesaving hat. I sit on the Victorian Medical Board for Surf Lifesaving Victoria, and I've been a lifesaver since way before I can remember. So in Victoria, and when you're thinking about setting up a first responder program or an AED program, I think I really liked what David said last night. It was have a think about who are those stakeholders that are not at the table, and who are the people in the community that we can tap into that might have skills, might already have defibrillators, but might be able to support that link, particularly those of you that are in rural and regional areas. And we can't continue, and financially, but also physically, to put an ambulance on every single corner of every single community. So the question really is, in order to strengthen that chain of survival and to continue to drive improved cardiac arrest outcomes, who are our partners and where are those bits that we're missing. So in Victoria, Lifesaving Victoria has 57 lifesaving clubs. We have 377 permanent seasonal staff. So it's a bit like the snow season. We have a bunch of lifesavers that work from November to April, depending on which state in Australia. But that's the predominant time where it's warm and where we're at the beach. But we have 32,000 volunteers. And we have who operate on Saturdays, Sundays and public holidays, and most of those locations are remote and regional locations that have an influx of community with all the same health issues that you would have in a metropolitan space. And so on average, they cover 3,420 hours of volunteer services. And so early in 2000, Lifesaving Victoria received a grant from the government to buy 10 AEDs. Now, at the time, AEDs were clunky, far less simple than they are right now. And in lifesaving, we implemented this really big training program. So where we look at where we've come to right now, but back then, you had to do a 4-day course, in how to use an AED. You had to do a resuscitation course, and it was just, very cumbersome and overwhelming with the administrative work that was there. Not to mention the reaccreditation all the time, the daily check processes and the system that we kind of set up inside to make that work was really clunky, and they were randomly housed, and the accessibility of them was completely random. And then we look at where we've come to today, and now, every single club in Victoria has multiple AEDs. They're linked in a system, and I won't talk too much about the linkage of the system, but they're now linked in a system, and they're part of our basic bronze medallion course. So it's a component on one session in the bronze medallion program for our 15-year-old kids. And we continually reaccredit that annually. So we've got a bunch of 32,000 volunteers now that are all trained in AED use, that know where the AEDs are. There are multiple AEDs at those locations, and they undergo regular annual reaccreditation and proficiency training. So, and when you have a look at, what do they do and why would we use this group of people? So Lifesaving Victoria predominantly came out of a rescue and resuscitation space in the early 1900s. But if you look at what we actually do, we do about 478 annual rescues, but we do 1,600 first aid cases. And so we've got a much bigger focus now in that life-saving community around, well, what's our core business and what's our core activities? And whilst we're there to make sure that we provide safe aquatic care, the predominant part of our work is to provide first aid and resuscitation. We've had about 10, the 2017-18 data is not published yet, but it is approximately the same. We had slightly more rescues and a couple more drownings last year than we did the previous year. But we see about 10 cardiac arrests on average. But those cardiac arrests are in rural communities where it might be, 18, 25 minutes for the ambulance to get there. So that's really that linchpin of, well, who's going to do something in that first space before the ambulance can get there? And if we compare that to, the journey from for fire in our state, and so in 1995 there was some research. Steve Bernard, our medical director, wrote a paper about the survival statistics and cardiac arrest outcomes in our community. And you can see from those statistics, no organisation would like to have statistics like that back then. And so it was a call to action from the government. We received some funding from the government to do something about cardiac arrest outcomes. And that was our, call to action, but that was our step that went, well, we need to actually, who else in our community has got our response capability and could undergo some training in that space to provide first aid or CPR and AED defibrillation to members of the community in cardiac arrest. And it wasn't without its challenges. So there were cultural challenges, there were, union challenges, there were payment challenges, but really it was about that drive to be able to go, well, we're not, our response time is, 9 minutes, and we've got this group of highly trained, highly skilled people that we could teach CPR and AED to that could actually support us in responding to the community. So that was the impetus, and that was where the AED or the Fire Brigade co-responder program started. And it was really about linking that middle link in that chain of survival. So, if paramedics are not getting there quick enough, and if you think about a link, if one of those links doesn't work, then the whole chain falls down. And you think about, well, what are the bits that we need to do along the way to strengthen that? And, that's where that responder and first responder program came out of. So we developed a group of people. We ran a pilot program in the CBD of Melbourne so that we could start small, and we made a whole lot of changes along the way. We had some training officers who were part of that program, and we rolled out a training program, as I said, in that pilot area. So we had 161 events in that area, and at the end of the 12-month period, we demonstrated that Fire Brigade could be successfully trained in CPR and in the use of AED, and that we can integrate that into a well-established ambulance response model in Victoria. So a couple of things that we learnt out of that, or a couple of things that we did along the way. We've talked a little bit about the MOU. We utilised Monash University to support some of that training. We had a team of EMR paramedic educators that were heavily involved in that training and that ongoing support. So it was one of the things that we very early, recognised was that the firemen joined the Fire Brigade to fight fires. And they didn't join the Fire Brigade necessarily to do CPR or to see SIDS cases. So we didn't differentiate on age when we started responding them to cardiac arrest calls. And so we worked really hard to support their mental health and their well-being. We produced some combined videos of how to deal with a sudden infant death situation, and we used some actors to produce a video so that we could, we had this captive audience, and getting the information to them wasn't our challenge, not like in ambulance necessarily. So they all have 24-hour fire vision in their firehouses, so in their stations, so they're giving them information and telling them stuff, and they have a lot of downtime. Wasn't the challenge, but it was about what were we going to tell them and what we were going to share with them, and what was the message that we were going to support them with. And so part of the EMR pilot or the EMR trainers was about supporting that mental health and wellbeing. And our trainers would go out to the fire brigade every time they did a cardiac arrest. So every cardiac arrest was debriefed, there was support and there was follow-up in that space. And we realised that that was a really big cultural shift in what they needed to do. So they were responded to priority 0 events only. And then if you have a look, we produced some data. We demonstrated that, the fire brigade probably got there a couple of minutes earlier in about 60% of the cases than what we did. And then we've now expanded that out to include our country fire authority. So in Victoria, Metropolitan Fire Brigade is in and around the CBD, and it doesn't, Melbourne is such a growing metropolis that the Metropolitan Fire Brigade sits well within what we would consider the metropolitan borders of our city. And so on the fringes of the metropolitan border, in built-up suburbs, we have CFA responders, and they're two separate organisations, politically and, structurally. And so in 2008, based on the success of the Metropolitan Fire Brigade program, we've then moved that training program and rolled that out into the Country Fire Authority, and are continuing to try and grow and expand that program. And what we've been able to do is that we've been able to reduce the time to defibrillation when we have CFA EMR response and improve that survival rate. And really interesting, I'll flick to the so that's just a little bit about, how many jobs and how many cardiac arrests that they go, and it's about 50-50 when they get there first. But this is the really interesting bit for us. So this is the bit where we have a look at all cardiac arrests and who got there first and when they were defibrillated. And the first responder program is up there with survivability, like our public access AED program. And this is the bit for us that is driving that expansion of that EMR program and how we can continue to link those co-responders and those first responders in the community. And, there are different organisations in different cities and in different spaces that might fill in that gap. But it's a really powerful message when you're trying to improve survival from cardiac arrest that our first responders are crucial, to continuing that, to drive that improvement in survival. So, we've done this along a journey. We looked at life-saving, it was a grant, here's 10 defibrillators. We started organically and we had lots of challenges, and we've grown to where we have an integrated system now. So in surf life-saving, we respond surf lifesavers to cardiac arrests in our space, and we would call the ambulance as well. So if someone has a cardiac arrest on the beach, then they would come and grab the lifesavers, and that's part of that response, and the lifesavers would call an ambulance response in that space. And we've grown organically from that with a pilot program with the Fire Brigade. And in 2016, the CAA joined forces with the Australian Fire Authorities to develop a joint statement that recognises the importance of first responder programs. So when you think about getting buy-in, you're thinking about who's at the table. Sometimes it's built organically from local relationships or some funding someone might get to start something. But the big question is, how do we continue to drive that and integrate that at a local level, at a system level, and then get government and politics and organisations to buy in, because it's really challenging sometimes at local levels. The politics gets in the way of stuff, and if you can go around that and have support from the top to help drive the system changes that need to happen, sometimes you get buy-in that way. So that's kind of all from me. Just a couple of key points. You have to have buy-in from operational leaders. You need to have buy-in from frontline leaders. There's a lot of training and cultural change that happened to have when fire brigades started responding to cardiac arrests and to priority 0 events. It was challenging for some of our operational staff. They're very quickly, we moved on from that, but you need to address that and put the elephant in the room when we're talking about how we work together. The training message needs to be simple. So when we started in life-saving, this 4-day program, because we taught them all about electrophysiology and what ventricular fibrillation was and why people have heart attacks, and we've very quickly learnt now it's just about putting pads on the patient when they're unresponsive. So that journey has been quite interesting. And to consider for some organisations, so for police, where they might not, where doing something might be restricted for the fact that they don't want to do EAR or they don't want to do mouth-to-mouth, we've come a long way. Consider just hands-only compression for some of those first responder groups if that's going to be a barrier for starting something. Start small. If you can't improve if you don't measure, so make sure you're measuring something about it, and learn from what doesn't work. Thanks.
Any questions for Michelle? There will be time for general questions afterwards, but any specific questions for Michelle regarding what they're doing in Victoria? Okay, no, thank you. Thank you, Michelle. I'd like to invite Dan Owes. Dan Owes is from St John, New Zealand, and Dan's going to touch on the St John, New Zealand experience.
Morning all. I was reassured by Tony that I didn't need to do slides, so I was delighted when Michelle presented her slides, so apologies in advance. From a St John perspective, so we have 3 groups that we predominantly engage in co-response for us, which is response to cardiac arrest within the community. So we have our prime network, so we have 450 to 500 doctors and nurses, mainly within rural and remote communities, who are trained by us to do to support ambulance within that community, and they respond to around 200 cardiac arrests for us a year. So we alert them to about 10,000 incidents. They respond to 4,000, and within that cohort is about 200 cardiac arrests. We also have a community response framework, so we kind of have Dan in a van. So we have people within the community where there's not the workload to justify an ambulance resource, and maybe there isn't a fire station. So we have someone who has a simple bag mask and a defibrillator, and they respond within their own vehicle for us, which is very good. But our primary mechanism for delivering early defibrillation within the community outside of using ambulance resources is through our partnership with Fire. So Fire in New Zealand is now Fire and Emergency New Zealand. So we first signed an MOU with them in 2014, a memorandum of understanding, which meant that they would respond to all cardiac arrests with us. And so that had some wrinkles. I'll explain that shortly, but basically our existing partnership with Fire sees 13,000 volunteers and 600 appliances co-respond with us, which is really cool. In the past, in the last couple of years, they've gone to about 80% of our cardiac arrests per year. 80% because the other 20% are either in rest homes, they're at doctors' surgeries, or they're witnessed by ambulance. So historically, we haven't sent fire appliances to those incidents. With our new high-performance CPR protocols, we'll be sending them to all incidents. And in the last year, 102 patients have been defibrillated early by Fire. We haven't seen the same amazing increase in survival which Victoria has. We've seen about a 4% increase. And we think that's largely reflective of the fact that in many of the areas where we've had defibrillators, we've also had very strong ambulance networks, because historically, under the old organisation before the merger, it was an urban fire service that we had been working with. Over the next 12 months, we're rolling out AEDs and supporting the training for all of the rural fire appliances as well. And so these are little fire stations in communities where we really don't have a lot of resource at all. It takes a long time for us to get there. So they're being kitted out with AEDs, and we expect that that will result in some really good changes for us as well. I think a lot of the challenges along our journey have been touched on by Michelle, and they're very similar. From my perspective, it's something that's very dear to my heart. I've been a volunteer fireman for coming up 20 years, and it's been really interesting to see the rhetoric along the way around, I joined to be a fireman, I'm not here to plug a gap for ambulance, etc., etc. And really interesting, when we first started to do medicals, you used to see people select which incidents they would respond to, because obviously you see the incident on your pager, and you can guarantee that if you had 20 people available, that 5 would turn up for a cardiac arrest. The amazing thing is that as we have come along on this journey with Fire, and we've had to give them some repetitive persistence, some very good people have had to front the media around some of the rhetoric that some of the unions had put up for us. As we see them come along this journey, actually, from a fire perspective, the interesting thing is that we now have 20 people turning up for the cardiac arrests and 5 turning up for the private fire alarms and things like that, which are mostly a waste of time. Anyway, so I tend to turn up for the medicals, but that's been a really nice change. And there's something quite powerful and quite rewarding when a 27-year-old who's got a congenital heart defect that goes into cardiac arrest, who's defibrillated by a fire brigade, turns up a month later, neurologically intact, to bring us muffins. You can't get any better in terms of driving home the message than that. The other couple of challenges that we've had along the way, so in the first sort of couple of years for us, it was around, I joined to be a fireman, I joined to squirt water, this isn't my role. And then that sort of went away, which was really nice. And then we got into this phase of, okay, if I get called to a cardiac arrest, I'm good with that, not an issue. But my issue is that sometimes I turn up and they're talking to me. Because of course, as we know, you turn up, we turn out fire to seizures and faints, etc., that sound like cardiac arrest initially. So fire said to us, gosh, cardiac arrest is now easy, but what happens if the patient's awake? That's really complex. So we've started to give them a few extra skills. We've given them pulse oximetry, etc., and we've asked them to focus, if you get there and that's the situation, on doing a patient assessment, getting us the information and making a phone call to our communication centre to talk with one of our clinical desk paramedics. And more recently, so that sort of noise has gone down, and then more recently we're starting to see an association, correlation, I don't know if you call it association or causation, so correlation between firefighter mental health and the introduction of responding to purple calls cardiac arrests. Now, the reason I use the term correlation is, while that's been highlighted recently, there was never any measures for firefighter mental health prior to this program being introduced. So it's only been introduced two years after. So it's we know that going to death is tragic, and we know that we need to support our colleagues, but it's hard to know whether or not there was that underlying tone there anyway, because obviously they were already attending lots of traumatic events. So we've developed a mental health first aid program which is available to fire. We've heavily encouraged our paramedics and intensive care paramedics, when they go to an incident, to say to the station officer, to say to the fire officer in charge, please stick around, we would like you to participate in the debrief. And that seems to be doing some really good things for us in terms of, all they want to hear, all the fire guys want to hear is, if the patient's deceased, the patient was going to die, there's no one that was going to change that. Even Tony Smith couldn't change that. So everything you've done is correct. And if the patient had any chance of surviving, then you've enhanced it. And when they hear that, you just see them breathe out a sigh of relief, which is interesting because that's the same for our own first responders, isn't it? So they like to hear that. So I guess those are the key messages from my point of view. It's a very brief summary of what we do. And I understand there's an opportunity for discussion and questions. So over to you, Tony.